Hello, everyone. I'm Daniel French, AFR's EMS training captain. We are joined today by Cassie Coleman. She is the Heart Hospital of New Mexico's LVAD Coordinator. She's also an RN, and she's joined us today to talk about some of the particular treatments and assessments that we're going to use when we run on an LVAD patient. So please tell us a little bit about yourself and how you find yourself in the LVAD Coordinator position.
It was not expected at all, but really enjoying my work. I am an RN. I worked CVICU for years, worked with heart transplant and LVAD at the bedside, and transitioned into this role at Heart Hospital of New Mexico in January of this year. It's a great program that is growing significantly. We went from managing 11 patients a little over a year ago to now 34, and we just hired another LVAD coordinator too to support our growth. It's a little bit of everything, helping patients who are seeking transplants out of the state because we don't have a transplant center here, and then just coordinating their care across the state in a vast range of towns and cities in the state as well.
How many of those patients reside in the greater Albuquerque area?
We have about 10 to 15 in the Albuquerque area, yeah.
Okay. So what do you think really should be the main things that we keep in mind when we run on these patients? And actually, I should probably have you start with just refreshing us on the main components of an LVAD.
Yeah, absolutely. So an LVAD is a left ventricular assist device. It is a device used for patients with end-stage heart failure. So it's a fully implantable permanent heart pump. And we use these either as their destination therapy. So this is what patients are living on for the rest of their lives. It can be a bridge to transplant. So if they are seeking transplant but maybe don't have the resources or the full workup or whatever it is to move out of state and pursue a heart transplant, they can have these devices to get them to that point. And it can also be a bridge to decision. So we can implant these on patients who, again, have met end-stage heart failure criteria and are deciding if they want to pursue a transplant later on. All LVADs have the same basic components. So there is a heart pump that is implanted surgically with open heart surgery into the left ventricle. There is a graft that goes to the aorta, and that pump just pulls blood continuously from the left ventricle to the aorta. There is a cord called the drive line, which exits out of the abdomen, and that connects the pump to a controller and then power sources. So they require continuous external power, either by battery or by wall power. And that's all of the different models have the same basic components there. Okay.
And it is definitely true that these patients are currently only alive because they're on the LVAD.
And with usually much better qualities of life, which is a very interesting and kind of new avenue in LVAD. That wasn't always the case, but it's something that we will only implant in people if we think that they're really going to benefit from it. So you will see them out in the community. You'll see them golfing, traveling, camping, hiking, working. So not probably what you have in mind when you think of patients with end-stage heart failure.
Nice. Very, very cool. Well, so what do you think some of the most important things as first responders to keep in mind if we are running on an LVAD patient?
Yeah. First thing, and this is what I teach all clinicians, is to go back to your basic assessment skills for these patients. We can get, kind of sidetracked by technology and tend to focus on that. But these patients are unique in how their physiology is and how they interact with technology and their equipment. So first and foremost, generally, if there's an issue on the pump or on the device, if you're having alarms, it's generally a patient problem and not a primary device problem. So your first instinct may be fix the technology, but it really should be fix the patient. What is going on with them? The other thing is, because of the continuous flow of physiology with these devices, they do not have palpable pulses oftentimes, and that can really skew our assessments of these patients. So it may be difficult to get automatic blood pressures on these patients. You may not obtain a pulse ox reading. various things won't work the way that we're used to them working. You may get a lot of artifact on EKGs from the electromagnetic interference. And so we have to go back to, are they awake? Are they alert? Are they mentating? Are they warm? Do they have good cap refill? Do they look comfortable? Those kinds of things. And instead of getting distracted by the technology.
Okay. So yeah, good basic assessment. We won't be able to necessarily rely on that 12 lead, right, to give us a good picture of what's actually going on with their heart. So treat the patient, not the machine.
Right. Okay. Exactly.
What are some of the most common reasons why we might be called to an LVAD patient?
Probably, first and foremost, I would say syncope. That's kind of our most common issue with patients, especially in the early postoperative period. Their body is adjusting to an entire new hemodynamic atmosphere, right? So these patients frequently will have falls and loss of consciousness at home that may be accompanied with an alarm on their device, typically a low flow alarm. So if we're looking at their flow or their cardiac output, it will alarm at 2.5 liters or less of flow. Those things are generally caused by orthostatic changes, right? So they just stood up too quickly and had syncope because of that. Could be from dehydration. So we have to alter their thinking. They've been heart failure patients. They've been restricting their fluid for years. And now the pump requires adequate fluid to do its job. And so they actually need to increase their fluid intake. And then hypertension can be another cause, which is not a very intuitive thing to think about. But if these patients have high blood pressure, it's actually restricting the flow coming out of the pump and can cause them to not get the flow that they need. So syncope would be one of the first ones I would think of. You may also have rhythm issues still. So their hearts still work alongside the pump and in tandem. And these patients can be tolerant of fatal arrhythmias more than people without an LVAD could be. They generally all have ICDs, but they may still have problems. So they may have VTAC, they may have VFib, and they may not be fully unconscious, but maybe having palpitations or issues with achieving the flow that they need in their pump. So,
and an ICD is going to be an implantable defibrillator.
Correct. Yes. Yep. So most of our patients have an implantable defibrillator before they even get their LVAD, and we leave that in, and it works as well. Okay. And then aside from rhythm issues, we have just other common health complaints, right? So we kind of get starry-eyed looking at the LVAD, but these patients are still at risk for hypoxia or pneumonia or regular infections or UTIs or whatever else. And so I'd caution people to not think that just because it's an LVAD patient, it's an LVAD problem, right? It might be something completely different.
I think if as someone that would respond to an LVAD patient, part of my mind is going to go to worst case scenario. Let's get them out of here. Let's see if we have to, start compression. It's probably not working. Mm-hmm. But kind of what you're saying is take a breath. Mm-hmm. Let's troubleshoot this thing, right? Maybe start with getting them fluid. Maybe see if we can give them a pressor and see how we can, support the pump, because the pump is probably working and there's something else going on.
Right. So spontaneous failure of the pump outside of just, battery draining is very, very rare. So if you encountered a patient whose pump was not working, first thing you would want to check is power and all of your connections, right? Are we connected to an adequate power source? And is their drive line connected to that controller? If those things are working and you still don't have your pump turning on, ideally you could have someone else troubleshooting while someone else was supporting the patient, right? So fluids, pressors, all ACLS medications. Caregivers are very extensively trained generally before they go home with the LVAD. They can teach you how to change out a controller if we needed a new, to switch to their backup controller. And we would try everything to get the pump working before we would jump to CPR, but CPR can be used as a last resort.
Well, so let's say we did show up and we're going to say that this patient is in cardiac arrest. How do we need to approach that differently, right, than our average cardiac arrest patient?
So like I said, first things first, try to restart that pump as quickly as you can. There is some nuance on if it's been off for a very long time. We do have a risk for embolizing a thrombus, right? So there is kind of a risk versus benefit. Are we going to cause a massive stroke if we restart this pump? I would say generally defer to trying to restart the pump because their heart comes before their brain, right? So try to restart the pump. If you can't, we can initiate CPR if needed, if your ACLS and fluids aren't working before that. We generally recommend CPR up and to the right of their chest. We do not recommend a Lucas or automated CPR device. And just keep in mind that CPR, there's a risk for dislodgement of that pump and massive bleeding. So it's something that we try to minimize at all costs. External defibrillation or cardioversion are okay. You don't have to do anything to the pump. Just try to kind of place it around where the pump would be for your pads. But all of those things are okay. And ultimately, you do what you have to do to support the patient.
Okay. Now, so what would be the best way for me to verify whether or not this patient does have a pulse or that the pump is working?
Yeah. So to look at the pump, if you look at the controller, there should be, at least on the newer controllers, there's a green, what we call a circle of life at the top. If it is illuminated green, that pump is working. If it's not alarming at you, if it's not got an audible alarm or a display on the screen, then it's working and there's not anything wrong with it. Another verification, if you're just questioning, is you can always auscultate and you'll hear a hum, a mechanical humming in their chest too. So you could confirm that way as well that it's working. As for verifying a pulse, right, most of these patients aren't going to have a palpable pulse anyway. So we are going to be, looking at consciousness, first of all, and just their general perfusion assessment, right? If you intubate, then you can look at end-tidal as well as a marker. So generally end-tidal less than 20, we would want to start CPR.
Okay. And it's probably worth pointing out that somebody else who is there as part of our response team needs to be on the phone with you as the LVAD coordinator, and your contact information, your cell number is actually in the ventricular assist device protocol in our protocols. So that number should be used as soon as possible to get a hold of you so you can really help our crew troubleshoot whatever problem is going on.
Yeah, absolutely. We have 24/7 providers on call that we can answer any questions. We can troubleshoot over the phone, equipment. We can guide their medical care as well. And I want to point out that even though that service is intended for our patients that we care for, there are, I believe, some LVAD patients in the community who don't follow with our team, and we would still absolutely answer that call and help troubleshoot for those patients as well. They may also have their own VAD coordinator number that you could call too, but we're always happy to help.
Now, so these patients are able to be very active because of this LVAD device. So the car wreck, some kind of traumatic accident, what are the things that we really need to be aware of in that case?
My first recommendation is careful with the trauma shears. They do have that drive line that's exiting out of their abdomen, so we want to be careful not to cut it. We want to try to locate all of their equipment as soon as possible, right? And if any of it can be salvaged, then we want to salvage it. A unique thing to remember with these patients is that even if their device fails and stops working, that does not mean that they are immediately dying, right? These patients lived for years, most of the time, with an EF of 10%, and oftentimes they can pick back up, just at their EF of 10%, and they can go for a bit without their LVAD. And so if equipment has failed, we're just going to treat them like any other patient, right? We're going to support them with medications and fluids and stabilizing whatever wounds or fractures or trauma that they have. And so do what you can as quickly as you can, but then follow your regular protocols as well.
Okay. And EF is ejection fraction.
Correct.
Right?
Yes.
Okay. We were able to interview a local LVAD patient, and one of the things that he mentioned was these are not waterproof.
Right.
So if you were, even removing someone from a vehicle and it was raining, that might be enough moisture to damage the equipment.
So yes, it's something that we have to be careful of. The drive line is okay. It can get wet. Patients can actually shower with their drive line exposed, but the actual controller and batteries and cables need to be protected. So, I mean, whatever you can come up with in the moment to protect it is fine. If you've got a blanket or something else that you can throw over it, that's okay. But it is something to be cognizant of, just trying to minimize moisture because it can cause failure.
Okay. So just to make sure, right, that I have kind of the high points covered. First and foremost, if we run a call on an LVAD patient, is we need to look up your number in our protocols and get the LVAD coordinator on the phone, right?
Correct.
We need to go back to basic assessment skills of LOC, capillary refill, the patient's skin color and condition, to be able to assess, because we might not be able to feel a pulse or get accurate readings from pulse ox, right, our blood pressure cuff, or even the LifePak monitor.
That's right. Yeah.
Okay. And then if we're gonna have to treat this patient, take out time to troubleshoot. Realize that more often than not, it's going to be some underlying problem with the patient, maybe a volume issue, dehydration, orthostatic pressure issues, right, as their body is getting used to this new device. And then if the worst case scenario, that the pump is not running, which, right, we're going to verify by looking at the controller, and if we don't see that green, right, circle of life, then okay, we know that the pump is not operating. There's a good chance we're going to have to do CPR for this patient. Only manual, right? No mechanical CPR. And you said the location
up and to the right a little bit of the chest. So trying to get away from the graft side of the aorta and the actual pump in the left ventricle, which that one's a little more protected, but kind of getting away from that graft site there.
And then fluid and medications like we would normally do. And then what might we see if this patient is doing a little better as far as a return of circulation?
Yeah. You may hear LVAD alarms stop, right? Okay. So if they were low flow, usually if they're not going to have adequate circulation, their right heart is not giving enough over to the left side for that pump to work, right? And so you're going to be getting LVAD alarms saying that there's low flow. So you may see a resolution of those alarms, and then just your general assessment of ROSC as well, right? Your end tidal is going to improve. They may begin spontaneously breathing again. Your assessment of their perfusion is going to be improved. So I would focus less on the LVAD itself and more just on the patient at that point for those things.
Well, is there any other points that you think we should know, or do you feel like we have it covered?
When we were going back through what we talked about, I think there were a couple of things that I wanted to just mention as well. I think I mentioned that the caregivers do get extensive training, but lean on them or lean on the patients if they are able to assist you as well, because they can help troubleshoot. They can help give you those phone numbers if needed. They usually go home with manuals or troubleshooting guides as well that they could show you. I would recommend getting as much of the equipment as possible, or having a caregiver or someone in the house bring you their equipment to transport with them. So their batteries, especially, but also their backup controller, so that you have that. And then we talked about how an automatic blood pressure may not be obtainable with these patients. Most patients do go home with a Doppler. I know that's not something that every truck might have on it. And so if you are able to get the family or someone to give you a Doppler and get a blood pressure that way with a manual cuff and a Doppler, you're just going to get one number, not two, and that'll be their map. But that can kind of help you in your assessment skills for them.
Okay. And then just to reiterate, we're going to call the LVAD coordinator immediately and know that we're transporting this patient to the heart hospital.
That's correct.
All right. Well, thank you so much for joining us today. We really appreciate it.
Yeah, thanks for having me.
All right. Thank you.